Okay,
Amy, it's all
perfect.
yours.
It's recording. Thank you so much. Good afternoon, everyone. I appreciate you joining this afternoon. The training came about regarding a few questions regarding sometimes sometimes CPT codes, discussions regarding some depression screenings, and a lot of CPT2 code questions came in for reporting measures where patients have aged out. So what Charles and I wanted to do is just kind of get together and take all of those questions that have been coming in and put them, um, into an agenda and put it into a training where we can all get together. And if we have any questions, we can discuss those questions and just provide a little bit of baseline training. So we're going to start with our reporting measures. And one of the questions that I received was, what about these patients with diabetes? What measures do we need to be picking up? What are the age limits of these patients? When do they age out? And so what I did was I went through and I put together a few of the high-level diabetes measures that actually need to be reported at least once a year, but they all have age out timelines. So if we're talking about blood pressure control for patients with diabetes, we're only looking at patients that meet an age requirement of 18 to 75. If your patient is 76, they have aged out of the reporting and they no longer have to have those reportings of the blood pressures for the diabetes. This is for type 1 diabetes and or type 2 diabetes. And we're looking for those blood pressures that are adequately controlled. We are not looking at anything over a 140 over 90 diastolic and systolic. This means that these patients are being controlled. It means that their blood pressures are being controlled with an underlying disease of diabetes. So we're typically looking for those 3074Fs, which is our systolic under 130, 3075F, which is systolic between 130 and 139, our diastolics under 80, and then our diastolics between 80 and 89. Now, another question that came in is, how often do we have to capture this information? And it is only one time during the measurement year. So CMS guidelines for HEDIS reporting, MIPS reporting, you only have to document it and capture it one time during the measurement year. Our measurement year begins January the 1st and it ends on December 31st. We also have statin therapy for patients with diabetes. This age group is patients 40 to 75. It only has to be captured one time during the measurement year. These patients cannot have any type of atherosclerotic cardiovascular disease. This is strictly a diabetes patient that is on statin therapy to control their statin for underlying diabetes. They have to meet the following criteria, though. They have to have received at least one statin therapy drug throughout the reporting year, and or we can report that that 80% of the members who maintained on a statin had an intensity of at least 80% of the treatment period, meaning that 80% of the time during the year the patient was properly managed for their statin medication and their adherence was at least at 80%. The next is the kidney health evaluation for patients with diabetes. This again does have an age group. It's age 18 to 85. Patient can have type 1 and or type 2 diabetes. And they have to have at least received one kidney evaluation during the measurement year. This could be either an EGFR or a urine albumin creatinine ratio, UACR, performed once, what resulted in the medical record, during the measurement year. The glycemic status assessment for patients with diabetes. So this is actually an age group of 18 to 75. It can be a patient with type 1 or type 2 diabetes. And their most recent HbA1c or their glucose management indicator was under 8% or over 9% during the measurement year. Now, with our reporting measures, we want to capture the one that was the best throughout the year, always. So we're looking at those glycemic indexes that were under 8%. We also have comprehensive diabetes care. And you notice that this is huge. This is one of the largest care management for HEDIS reporting that we have. It's patients 18 to 75. They have type 1 and or type 2 diabetes. They have an annual screening located in the medical record and documented of at least one lab value of an HbA1c that was less than 8%. The patient had a diabetic nephropathy assessment. And of course, we're looking for those controlling high blood pressures. We're looking for those blood pressure measurements that are less than 140/90 for patients that also have hypertension. I gave you a list, and we're not going to go through all of them. If you have a question after reading these, we can definitely discuss it before the call ends. However, these are just a handful of the comprehensive diabetes measures and those CPT Category 2 codes that go along with those measures. Now, we do have patients that age out or that are excluded from HEDIS measurement reportings due to an advanced illness or frailty criteria. So advanced illness is going to include those conditions such as metastatic cancer, patients that have heart failure, and late-stage kidney disease. Frailty codes are typically included with equipment on claims such as hospital beds, the patients are wheelchair-bound, and they require oxygen. And so another thing that can tip that patient into a frailty category is the documentation of weakness, documentation of frequent fatigue, and or documentation of frequent falls. And so what I did was I gave you the members that would be excluded from the HEDIS measurements based on an age group with advanced illness or frailty and or a patient that's 81 years or older that has frailty documented. And so our breast cancer screenings are patients, women aged 50 to 74. Colorectal screenings are patients 50 to 75. Our controlling blood pressure, again, is 18 to 85. Osteoporosis management in women who had a fracture is only captured between ages 67 and 85. Our comprehensive diabetes care is age group 18 to 75. Disease-modifying anti-rheumatic drug therapies for rheumatoid arthritis. So if that patient is between 18 and there is no cutoff, there is no cutoff age limit for the anti-rheumatic drug therapy for a patient that is on some type of drug for rheumatoid arthritis. Now, I did provide the statin therapy for patients with cardiovascular disease because they are not included in the diabetic patient monitoring because they have cardiovascular disease. For men, it is age 21 to 75, and for women, it's aged 40 to 75. Now, when we talk about breast cancer screenings, the patients are going to be included from the measure if they have a history of a bilateral mastectomy. Okay. If they had cytology during the measurement year or 2 years prior. So, I'm sorry, include the following diagnosis codes on your claims. So if this patient has been excluded from the measure because the patient no longer has breasts to screen, Z90.13 for the acquired absence of bilateral breast and nipple, Z9012 for the acquired absence of the left breast and nipple, and Z9011 for the acquired absence of the right breast and nipple should be reported on the claim. That allows the insurance company to know that when you assign those diagnosis codes, that these patients are going to be excluded from these measures. It is typically reported on women aged 50 to 74. So there was a question that came in regarding all of these screenings. When do they age out? You do not have to report breast cancer screening measures on any person or woman that is over the age of 74. We also had a question come in regarding cervical cancer screenings, and it was actually related to Q0091. And the question was asked, again, when do these women age out of these screenings?
I'll get these slides.
And so it's only captured for women 21 to 64, but they have to have had a cytology measurement during the reporting year or 2 years prior. The documentation has to be in the medical record that indicates the date that the cytology was performed. The final result or finding has to be documented in the medical record. And any biopsies that were performed, any breast ultrasounds that were performed, or any MRIs that were completed during the measurement year do not count towards any of these cervical cancer measures. And I have listed out the reporting codes for you. Colorectal cancer screening, they age out at age 75. So the age capture for colorectal screening is 50 to 75. Once that patient meets the age of 76, you no longer have to pull or report colorectal cancer screenings. A fecal occult blood test can be performed every year. A FIT DNA test is only allowed to be performed every 3 years. A CT colonoscopy for a normal, healthy patient that does not have risk or a history of polyps is performed every 5 years. Again, same criteria for flexible sigmoidoscopy every 10 years, every 5 years. And then a colonoscopy should be performed every 10 years between 50 and 75. A note indicating the date when the colorectal cancer screening was performed is required to be in the medical record. And you have your reporting codes. And then I gave you some ICD-10 codes. So Z85038 is a patient with a personal history of other malignant neoplasm of the large intestine. And Z85048 is a personal history of other malignant neoplasm of the rectum, the rectosigmoid junction, and the anus. Does anyone have any questions regarding the HEDIS measures before we move on? Okay, perfect. So now we're going to go into brief alcohol misuse counseling. And this was another question that came up because these are timed codes. And so these timed codes, our documentation has to be spot on when we're talking about timed codes, because in behavioral health and a lot of these annual screenings and brief face-to-face encounters with these patients have to meet a minimum threshold. So let's talk about GO442, which is our annual alcohol misuse screening. Now, our timed requirement is 5 to 15 minutes. Our documentation must clearly define that we spent 5 minutes with that patient face-to-face in their annual alcohol misuse screening. If it's less than 5 minutes, there is no code that can be assigned, because we have to meet the minimum requirement or the minimum threshold of that CPT or HCPCS definition, which is 5 to 15 minutes. Now, on the other hand, there is not an add-on code for additional time. So they are saying we're going to give you 5 to 15 minutes. There is no add-on code for additional time that's spent with that patient. GO443 is the brief face-to-face behavioral counseling for alcohol misuse. In this code, we must meet a 7-minute threshold with that patient. So the documentation must support that at least 7 minutes was spent with that patient in brief face-to-face behavioral counseling. So GO444, our annual depression screening, and our G8510. So under our GO444, it has to meet the minimum threshold of that 5 minutes with that patient documentation being face-to-face encounter. G8510 does not need to be reported if the depression screening is negative and there is no follow-up with that patient. So if that PHQ-9 or that PHQ-2 is performed and it's 0, the patient has negative depression screening and there is absolutely no follow-up recommended for that patient, then the G8510 does not need to be reported. If that patient is provided a PHQ-9 and it is not during an annual wellness visit, you can capture that brief emotional behavioral assessment, such as a depression inventory, attention deficit hyperactivity disorder scales, and there's a CPT code for that. It's a 96127. So if your patient comes in and it is not an annual wellness visit, or it is not a welcome to Medicare or a subsequent Medicare annual wellness visit, and you have to perform a PHQ-9 or a PHQ-2, the documentation supports that you scored it. For each standardized instrument that was obtained that day, you can report the 96127 for the testing. Another question that came in was regarding the influenza administration code, the G8482. And so the G8482 is influenza immunization that is administered or previously received. Now, we do not want to report the G8482 if the patient comes in June for their annual wellness visit and they don't have it and they received it 2 years ago. Okay, what we need to do is we need to make sure that these are in the same reporting year. So if we're reporting this influenza immunization that was administered or previously received, let's say that we're seeing a patient for a 6-month follow-up, and we neglected on their annual wellness visit to report the G8482, and that patient had their influenza administered during their annual wellness visit. We can absolutely utilize that time to go back in the chart for that reporting year and make sure that that patient was provided an immunization during that reporting year. G8483 is an influenza immunization that was not administered. This has to be documented in the medical record by the clinician, and it has to note that the patient was allergic to the influenza, or the patient just declined the influenza administration. And then we have another G8484. And this is the influenza was not administered at any time during the reporting year, and there was absolutely no reason given as to why the patient did not receive it. Again, at the bottom, I've given a little bit more clarity of reporting each payment year. So it should be reported each payment year unless the vaccination is not given. So we should not report a code for the measure. the vaccination was given in the prior year reporting, so we do not report the measure, and it does not matter what time frame within that reporting year or reporting period that the vaccination was given. And then the last thing that was asked is to give a little information on transition of care. I think it was called TOC in the email, but it's actually the Transition of Care Management, TCM. And so we do have two, as a matter of fact, CPT codes that talk about or cover transition of care. And those CPT codes are 99495 and 99496. And they are for an established patient whose medical and/or psychosocial problems require moderate or high complexity medical decision-making during the transition of care from an inpatient hospital setting. And this includes acute hospital, rehabilitation hospital, long-term acute care hospitals, partial hospitalization, observation status in a hospital, or skilled nursing facilities. And even to the patient's community settings, such as a home or domiciliary rest home or assisted living. The transitional care management commences upon the date of the patient discharge and continues for the next 29 days. And so for the 99495, the transitional care management services with moderate medical decision complexity, face-to-face within 14 days of discharge. It requires communication, and this can be by direct contact with the patient via telephone or via some type of electronic audio-visual communication. This is with the patient and or the patient's caregiver within 2 business days of that patient being discharged. It requires a medical decision-making of at least moderate complexity during that service period and requires a face-to-face visit within 14 days of discharge. We also have the 99496, which is transitional care management services with high medical decision complexity. It also has to be completed face-to-face within 7 days of that patient discharge. It requires, again, communication, whether it be direct contact, whether it be via telephone, whether it be electronic or audio-visual communication with that patient and or their caregiver within 2 business days of the discharge. The medical decision-making has to be of high complexity during that service period, and it requires a face-to-face visit with that patient within 7 days of discharge. So because the transitional care management services described by 99495 and 99496 involve at least one face-to-face encounter or visit, CMS believe that they represent a primary independent service that should be separately payable when assigning those CPT on 99495 and 99496. CMS also noted that these could be short-term payment strategies that may be modified or revised over time to be consistent with broader primary care and care management initiatives. So we really need to be diligent in looking and making sure that CMS does not come in and broaden those primary care and care management initiatives. We need to be very diligent in the updates that are coming in on CPT for January 1. Our HCPCS codes come in for January 1, and making sure that these have not been further expanded to capture more information. I did want to provide what the difference is between a moderate and a high decision-making status is, because there are a few differences between a moderate level of medical decision making and a high level of medical decision making. So under moderate, the patient has one or more chronic illnesses with an exacerbation, a progression, or a side effect of treatment. They could have 2 or more stable chronic illnesses. They could have one undiagnosed new problem with an uncertain prognosis, or they could have one acute illness with some type of systemic symptom, or one acute complicated injury. So we also have the amount and the complexity of data that has to be reviewed and analyzed to meet a moderate requirement. So at least one of the 3 categories, we have to meet at least one of these. And this is ordering tests, documenting patient conditions, reviewing independent historian information. And so review our prior external notes from each unique source. So the patient's coming in, you're doing transitional care management, you're reviewing their hospitalist note, you're reviewing their nephrology note, you're reviewing all of those external notes from each unique source. You're reviewing results of testing that was performed. Let's say that you decide that you want to order some additional testing, or an assessment was required as an independent historian. So their caregiver, their husband, their daughter, their sister-in-law is giving the information to the provider. In the second category, we have independent interpretations of tests, meaning that you are interpreting a test that was performed by another physician or another qualified healthcare professional. And then discussion of management or test interpretation. So you're actually discussing the management or the test interpretation with an external physician or other qualified healthcare professional of an appropriate source. And then the risk of complications of morbidity or mortality during that patient management. And this could be prescription drug management. This could be decision regarding a minor surgery with identified patient risk. Decision regarding elective minor surgery without the patient having any identified risk factors, or the diagnosis or treatment significantly limited by social determinations of health. Our high is one or more chronic illnesses with severe exacerbation, severe progression, or severe side effects of treatment. It could also be one acute or chronic illness or injury that poses a threat to that patient's life or to bodily function. Or it could be a multiple morbidities requiring intensive management. And this is a set of conditions, syndromes, functional impairments that are most likely to require frequent medication changes, treatment changes, or significant reevaluation of those patients. The patient is significantly at risk of worsening, including medical or behavioral status, and the risk for readmission or status readmissions to the hospital. Again, we still have the extensive, we have to meet at least 2 out of the 3 categories for data. The data is the same, and that our high risk of morbidity from additional diagnostic testing, drug therapy that requires intensive monitoring or toxicity, decision regarding elective major surgery with the patient being identified as a procedure risk, decision regarding emergency major surgeries, decision regarding hospitalization or an escalation of that patient to hospital level of care, DNR or de-escalation because of a poor prognosis of that patient, and para-enteral control
Hi,
substance.
Anna. This is Tanya Brock. I was calling. I submitted an application to add a rural health clinic to our membership, and I just need to make a payment for that. I talked with Tasha, and she told me to work with you to make the payment.
Okay, so I'm hearing a lot of feedback. If we could please mute.
It's Advent Health Manchester.
Thank you so much. So I had a few questions come in, and are the minutes
That's
provider
correct.
time or does nurse time count? This is provider time only. It can only be documented by the provider or other qualified healthcare professional.
Mhm. And then
Is
we
the
actually
reporting
have
year
another
the
one coming
calendar
on
year?
board fairly
Yes.
soon. Would it be best if I go ahead and add it
I
now, or
hear
just wait? It's not
Tawana
went
Brock
through the
talking.
certification
Tawana, if you
process
could
yet, so I
please
was
mute your
kind of
phone.
waiting and thinking we needed to do that first before we added them.
Yeah, I'm trying to think. I think we can add them before they're officially an REC, but that's up to you.
Okay, let
And
me,
then the last
I will
question,
check with my team and then I'll get back with you. All
Sounds
righty.
great. What is payment information? What is the billing information?
Tawana, if you
It's
could please mute
under
your
my name,
phone.
Tanya Brock, Tawnya Brock.
Tanya, if you could please mute your phone.
195 North Myrtle Avenue, Jellicoe,
Okay, if someone's with
Jellico,
Tanya, could
Tennessee,
you please ask her to mute her computer?
37762. That'll be
Let
my
me see
cell
if
at
I can mute
606.
her. There we go. Thank you so much. Let's see. When a patient refuses a performance measure, can you use modifier 2P on the CPT2 codes? Yes, absolutely you can. It has to be documented in the medical record clearly that that patient refused that performance measure. But absolutely that 2P can be assigned if the patient, again, is in the age group or the age reporting. And so I'm going to open it up to any other questions. Does anyone have any additional questions that you may want to ask for clarification?
Amy, can I ask you a question about TCM?
Absolutely.
So wondering, can you bill TCM with all the paperwork in place for an existing nursing home patient that goes inpatient to the hospital, then goes back to the nursing home, and you indeed have phone calls with family of the patient themselves, or the nursing home staff that's caring for them? Would that qualify? And can you bill the TCM, or would it be more proper to bill like a 9930 4, 5, or 6 as a new admission code, or even an existing code? So just wondering, can you do TCM on people that are not coming to the outpatient clinic and going home after the transition? They're going back to a long-term facility. Is that allowed?
Absolutely, it is allowed. Of course, we do have the 99495 and the 99496 for the transitional care management services as of right now. So yes, if that patient is being discharged back to the nursing home, it meets the transitional care management. As long as you're having direct contact with that patient via phone, patient caregiver, within 2 business days of that patient being discharged, your medical decision making is documented of at least a moderate complexity, and that you have a face-to-face encounter with that patient at least 14 days after the discharge, or the patient goes back into the skilled nursing facility. Absolutely, you are meeting every requirement that you have to meet for that transition of care.
Thank you.
You are very welcome. And I received another question. It says, I believe in 2025 is when we have to report our clinical measures electronically, our ECQMs. Do you think it would be redundant to focus on CPT2 during this period, assuming we are only interested in focusing on Medicare? No, I do not think it's redundant, because all of your ECQM measurements are reported in different ways for different things. So your ECQMs could be reported for your clinical measures, but what happens if you only focus on Medicare and you have Medicare Advantage patients that are commercially qualified? It messes with your HEDIS reporting, it messes with your STARS reporting, and it messes with your population health risk adjustment factor when you're submitting for those baselines for the next year.
Amy, this is Dr. Siefkin. I'm a little confused on the influenza thing still. So say I see a patient in January for my wellness visit, and they got their flu shot in December prior to that visit. What code would you pick for that?
Okay, so that is a good question. All right, so let's take a look. It would be the G8482, the influenza immunization administered or previously received.
Okay, but it's in a different reporting year.
That is correct. So that patient is not actually going to be ready for that immunization until January of the following reporting year. So because they get one once a year, right? It's a once a year influenza administration.
That's correct.
Okay, so if we're doing it in a January annual wellness, and they got the flu in December of, let's just say that the patient came in on January 2025, January 9th of 2025, and they received their annual flu vaccination on December the 9th of 2024. They're always going to be within the following reporting year. So as long as you can document that the patient previously received it in the previous reporting year, you're still meeting the requirements of the G8482.
Great, thank you.
You are very welcome. Does anyone have any other questions or anything that I can clarify?
It's Dr. Siefkin. I can keep going. The diabetes measure for nephropathy, the kidney issue with diabetes, is it a GFR or a urine a protein to creatinine ratio, or is it an and?
No, sir, it is an or. So the patient either has to have a documented eGFR during the reporting year or the UCAD during the reporting year.
Thank you.
Amy, and along those same lines with the diabetes, for instance, you have all the CPT-2 codes about different measurements, you know, the ACE inhibitor, the statin. How many would you recommend reporting? So say you mentioned this has to be once a year. Would you say that at every checkup, you should just put it in there because maybe in your January annual wellness visit, their A1C was 8.5, but then you see them quarterly, and then by December, you've gotten it down below 7. You know, just in the incidence of making sure you don't miss it, should you just do it every visit? You know, foot exam, all those codes, what's your recommendation on that for how often, although it's only reported once a year? What you just don't want somebody to choose a data that maybe isn't the best.
Absolutely. And you always want to send your best measures throughout the year to the insurance company. So what I would recommend is the patient comes in for annual wellness visit. Typically, diabetic patients are seen on a follow-up basis of once every 3 to 6 months. And so on that 3-month and that 6-month visit, I would capture not necessarily the foot exam and all of those CPT codes, but I would report the HbA1c if it was better or if it was worse. I mean, I would capture those results on the 3 and 6 months, and then maybe I would pick up the controlling blood pressure, because maybe the patient's blood pressure was 145/96 when they came in for their annual wellness visit, and we've done some changes to their medicines. Their blood pressure's now, 117/73, and they're doing fantastic. So now that measurement is going to actually be better than the one that was captured during the annual wellness visit. So I would recommend 3 to 6 months, 3 and 6 month follow-up visits. Does that answer your question, Dr.
Yeah.
Thomas?
Yeah, thank you.
You're very welcome. I received a question that says, do we use G8482 if the patient receives the immunization at the pharmacy? If the documentation is listed within the medical record and is part of the medical record, and you document that the patient received it, what date they received it, and where they received it, yes, you can absolutely capture the G8482.
Amy, it's Dr. Siefken again. I've got a subset of patients that just don't trust the government, and they are just not interested in an annual wellness visit. How would you suggest we go about reporting to people that we're trying our level best to get at least parts of the annual wellness visit done without all of the paperwork that they're worried about is going to go to the federal government?
Oh, goodness. That's a little over my head. I'm so sorry. I mean, it is so important, especially for Medicare Advantage patients and Medicare patients, to receive their annual wellness visits. They're welcome to Medicare visits and their subsequent follow-ups, because it allows so many different things. It allows ICD-10 codes to be further specified dependent on how often they're reported. It allows for the expansion of CPT codes for proper capture of procedures, E&M levels, CPT-2 reporting codes for capture of all of our measurements. That's not something that we can tell the patient and get it to them that how important it is. I'm not sure. I have noticed over the past couple of trainings that I've had with different providers that they're saying the same thing, that these patients aren't trusting the government. They do not want their mental status reports being sent in for documentation. I think that may be something that you and your ACO director, Charles, may want to get together and maybe come up with just a few bullet points to talk to your patients about scheduling those annual wellness visits and how important they are.
Yeah, I understand. I've been doing my level best to not call it a wellness visit and to report that modifier 2P whenever I can on the CPT-2 codes. Just trying to do something, but I don't know.
Kind of along the same
Yeah,
line.
I'm at a loss.
What if you had a patient that had that was agreeable to do the annual wellness visit, but they refused to do part of it? For instance, the mini mental exam or the mini cog or something. And to Dr. Siefken's point, you could maybe find a way of putting in a 2P or something, but you did the annual wellness visit, so you should report it, but the patient refused to do a part of it. Is that still appropriate to report that you did it, even though the patient was non-compliant?
You can only report the parts of the annual wellness visit that were performed. You can't say I did an annual wellness visit and not meet all of the elements that are required for the annual wellness visit.
Okay, gotcha.
So then if the patient comes in, we would have to do an E&M level and capture the E&M level instead of the annual wellness visit. Because those annual wellness visits, they require, all of the elements, and it's a pretty good chunk of the annual wellness visit for, the PHQ-9, the mental health status, the fall risk, all of the underlying annual wellness visit for the preventative labs that have to be ordered and performed. It's just a lot, and you would absolutely have to carve out which things you did and which things you didn't do. on the checklist for the annual wellness visit.
Okay. That's helpful. Thank you.
You're welcome. It's becoming harder and harder to be a provider. I understand your struggle.
I've got one more thing on my mind, if you don't mind.
Absolutely. Go ahead.
So about making sure I understand kind of like the G code for the breast cancer screening documentation. And I think there's must be a CPT2 code for the colorectal cancer screening. But in terms of the G code for breast cancer, we would only put that code in if the same reporting year, we either have documentation that they did it somewhere that calendar year, or that we ordered it and received it, kind of to close that loop, correct? I guess the question I have is, to Dr. Schiefkin's point earlier, they did it in December, but that they're just not on the ball for doing it 12 calendar months later. So when they come back next December for their AWV, they say, yeah, I got the mammogram, the hospital canceled my appointment. I can't get it till February. Technically they're due, but I reviewed their most recent one. You know, how would you handle that situation? Because the reality is it's hard enough to get people in on the same calendar month. It takes a lot of office planning and prep work and things to do. But nobody gets their flu shot in the same month every year. Nobody gets their mammogram the same month every year. There's always snafus behind that. So if you're on that calendar month into the next year, you kind of get, it's a disadvantage for us.
Absolutely. And as long as the patient meets the age requirements, as long as you have documented in that progress note that you reviewed the last screening breast cancer mammogram that was performed, it is absolutely one that you can pick up. That is your screening measurement. Because remember, all you have to do is provide the documentation that you reviewed it and when it was done.
So whether they're overdue or they're right on target or they've had it, any of those would suffice for this measure, just saying, I reviewed the most recent one I could find, even if it was 5 years ago and they're behind the 8 ball, I reviewed what was in front of me and we made a plan to do it this next year or whatever, that you could also appropriately put the G code.
Absolutely, because in your scenario, the patient's 5 years overdue, you're going to schedule a screening mammogram for that patient during that encounter.
Got it.
I mean, I would typically think that you would say, hey, look, you haven't had a screening mammogram in 5 years. Let's go ahead and get you one scheduled. As long as you ordered it, you are fulfilling that screening because you've ordered now for the screening.
Okay. This has been really helpful. Thank you. Just kind of figuring out when to report the measures and what the wording means and everything, because it gets kind of hairy. You could have 25 G codes put on an AWV. How many is too many? That's kind of the helpful part of this, is just to know what's critical to make sure that we put, because we're doing these things, but if we don't report it, you don't have proof it was done.
Absolutely. And you are so right. There, you could fill up 10 CMS 1500 claim forms with just reporting measures. So that's when it's important for the ACO to get together with the providers. And a lot of people just get together and have the top 10 or the top 15 measures that are required to be submitted. And they come up with their reporting measures. So that may be something that you want to look at with Charles, is to talk about, you know, what measures you have now, what measures could you put together and lump them into certain CPT2 codes for reporting. Or if you're doing that, you know, outside of an annual wellness visit, if you're doing all of those elements for that complete diabetic comprehensive exam for that 1 year, just take that one and make sure that you pull all of your CPT2 codes that go underneath that measure. And that way that measure is covered for the year.
Excellent. Thank you, Amy, very much.
You are very welcome.
Amy, this is Krista. Wanted to ask with regard to the timed codes that you started with the presentation, you would expect to see if someone billed for a G0444, 5 minutes recorded in the documentation?
Yes, I would expect as a clinical documentation improvement specialist to see how many minutes were spent with the patient in the counseling.
Thank you.
You're welcome. Anybody else? I am so thoroughly enjoying this, by the way. This has been just a great education session. Okay. Well, if we don't have any additional questions, I'm going to give you 7 minutes of your time back today. Please make sure to reach out to Charles or anyone on the team if you have any additional questions. He'll send those to me and I'll make sure that I get back to you in a timely manner.
Amy, this is Tanya.
Thank you.
Thank you.
Thank you so
Thank you
much.
very
Have a
much.
wonderful day.